so much for this opportunity. Um, I'm Tari. This is my full name. It's quite long, so most times I go by Tari. PhD student, P of the Department, University of Houston. Um, Today, I'm really excited to present our work. It's a work in progress as well, just like the other speakers. And for the purpose of this presentation, I'm just going to really focus on the implication for policy and practice. So this work is on the determinants of racial and ethnic disparities in cardiovascular preventive service use amongst adults in the United States. So these are my advisors and collaborators for this work. And we're still doing some bit of analysis on this, adding more years of data together, but I would share what we have for right now. So this is the outline of the presentation. And as we know, cardiovascular disease is the leading cause of death, the number one cause of death actually in the United States. And the current economic burden has been projected to be 378 billion, and that is expected to rise even to $818 billion in future in the year 2030. Studies have shown that if we engage preventive services like preventive care, the US could save up to 41 billion every year in Medicare costs. However, about 50% of Americans do not utilize these services efficiently. And so the United States Task Force had taken up the initiative to address this disparity and calls for more research in this area, which was our major motivation for doing this study. So our study objective aims to examine the racial and ethnic disparities in the use of cardiovascular preventive health services amongst US adults. And we also want to measure the influence of the observed factors and how they contribute to these disparities using a method called the nonlinear blinder or Hacker decomposition. It's not really that complex. I'm going to break it down a little bit in the next slide. So this is a big data analysis, retrospective cross-sectional study. We use the MEPS data. This is a publicly available database, secondary database. And the duration was set for 2018. And this is what the MEPS data looks like, the snapshots here. This website shows, if we want to take a look at the MEPS data later, anyone who is interested, is publicly available. So it's a nationally representative data. And the beautiful thing about this data is the fact that it overpopulates the minority population in order to have a representation of what the actual US population is. So it's really a good data for this study. So we went about getting our final cohort by including people without CVD that are captured in the 2018 data. So all of the persons that have CVDs were excluded from the data, and we used the ICD codes, these ICD codes, to exclude them. And these were the diseases labeled as CVD that were used to exclude these patients. And finally, we had persons who had what they call the clinical preventive care self-administered questionnaire. If they have complete information on that questionnaire, we included them in the final cohort. And so this is how we went about analyzing the data. I won't bore you with all of this stuff, but our main outcome was whether a person received preventive service screening or not. And then we had our demographic variables, or the covariates, and the primary independent variable was race and ethnicity, meaning we wanted to see how the disparity occurred across the different race and ethnicity. So we did that on the SAS software, did a descriptive analysis, multivariable logistic regression, and the Blinder-Hacker decomposition. This analysis just simply breaks down disparity into observed factors and unobserved factors. The observed factors are the factors that the data set could explain, and the unobserved factors are those factors that could be due to things or factors that cannot be measured based on the information we have in the data. So this is what our demographic looks like. Overall, the study sample consisted of people who do not have CVD, like I mentioned earlier, and most of them were younger females, as we can see. And the racial differences in the study between whites and other races, whites being more as compared to other racial groups. Moving forward, we have this as a multi-logistic regression for CVD preventive service use. Here we see that Black individuals are 26% less likely to receive these services as compared to whites. And also Hispanics had lower odds, as we can see, of receiving the CVD preventive service, although this is not statistically significant, but it's something to take note of as we move on in our, in our analysis. Also, people who are greater than 65 years are less likely to receive these preventive services, while females are more likely as compared to males to receive preventive service. Sorry, looks like this is not full. Okay. So I'll talk about this quickly. So for our Zaka-Blinder decomposition analysis, we found that the predicted probability of using cardiovascular preventive services was 0.00285 for whites and only 0.005. It's already obvious to see that there's a disparity there. So when the disparity was calculated, we had a 0.00235, or we can call it 0.24 percent points. This disparity, there was no significant difference between the Hispanic population and the white population when it comes to the use of the CVD preventive service. And so we had to remove that from our analysis. So what this means is that since the decomposition yielded a negative coefficient, which we can see here as 0.015 for the racial disparity, it suggests that the observed characteristics could not really explain the gap that exists between white and Black in terms of the use of preventive service for cardiovascular disease. So what that simply means is, even if there were no disparities, like the Black population had exactly the same characteristics as the white population, the disparity would still persist. We will still have a 63.6% of the observed difference. And the significant contributors included age, gender, educational status, and marital status. And among this, it was the only factor that was significant, as we can see here, is the marital status. Excuse me, I don't know why this keeps moving. To conclude, I would say that this study, the significance of the study to policy and practice is that targeted intervention needs to be there is a need for targeted intervention, and then there's a need for enhancement of policies that would encourage or help the population with disparity, the Black population, especially, which is the vulnerable population in this scenario, to engage more with the preventive service use. Also, One of the strengths that this study have is the fact that we use a nationally representative data and a robust method to try to really, really keep it simple here. And it's an area that's really critical for public health, being like the number one cause of death, and knowing how much prevention can contribute in averting the debt, as well as save costs, not just for the United States, but globally. However, we had limitations because we used the 2018 data, and we're working on expanding that analysis further. And since it's a cross-sectional design, we cannot establish causality with such design. We can only look at the associations. Yeah, so I would like to conclude by saying that there is need to address these disparities. Although the data that we have cannot absolutely answer all the questions, we need to do further research to examine other factors that are not here present, like beliefs, behavioral patterns, and all that, as how they affect these disparities that we have identified. I would end it at this point, so I let the other speakers say thank you so much to all my advisors. These are my advisors, Essien and Osaro, and these are other collaborators. Thank you, Paul. Thank you to your team and other speakers and the audience. I'll take questions now.
Great. Thank you, Terry. Are there any questions for Terry? I have one quick one. I mean, you mentioned that, you did this here in the United States. I mean, could this kind of work be done in countries like Nigeria? Do you need special equipment other than the software programs and that sort of thing?
Yeah, I mean, it can absolutely be done. I have been exploring a lot of data in Nigeria. We don't have as much structured and organized data system. We're trying, like the DHS data, but we don't have like some of the variables that we have here. But something can be done. I'm really looking into it, and I've been working with other people to see how access to data can be improved in Nigeria. So it can really be replicated. Yeah.
And when your studies are done, is it your intent to go back to Nigeria, or do you want to stay here in the U.S.? I know that's a personal question. It may not.
I came from a faculty position, so I would most likely, go do what I have to do. But I would also like see how to explore the opportunities here. But I'm really passionate about, giving back and improving my country's health system, which is something I'm really passionate about. So
sure,
I might be here and there,
Okay. Well, we hope to keep the conversation going by all means, wherever you are.
Yes.
Okay.
Yes. Thank you.